Alright, so we're going to go ahead and start part 4 of the hypertension pharmacotherapy lectures. So the first drug we have here is aliskiren. So this drug also works in the RAS system, just like ACE inhibitors and ARBs, but it works by directly inhibiting renin. So remember, renin converts angiotensin to angiotensin 1. So it works earlier in the process than the ACE inhibitors and the ARBs. Because it works in the same pathway, though, we should not combine it with ACEs or ARBs, because even though they're a different class, aliskiren is its own class, it's still a little bit of a duplication of therapy because they're all working in the same exact pathway. So has pretty much the same safety, side effects, monitoring profiles as ACEs and ARBs. Funny story about this drug, though. When I was in pharmacy school, we had field days and we would compete a lot of outdoor activities and obstacles and games against the other classes, and my class was super competitive, so we went all out and we got jerseys, and everyone tried to find a drug that had a piece of their name in it to put on the back of their jerseys. So I only had two options. One was crystallose, which was pretty cool because the way crystal is spelled in crystallose is exactly how I spelled my first name, but I was like, that's a laxative, that's gross, I don't want that to be on my jersey. And my other option was this drug, which we hadn't really covered in my hypertension lecture because it's not really frequently used. So one of my professors suggested it to me. It was like, oh, look up aliskiren, the brand name. My maiden name is Urena. So he was like, you could, throw it in there and be like Tecturena or something like that. But I thought that was really lame too. So just use my last name. Anyways, totally irrelevant story. Let's get back to the lecture. Same points for the most part as ACEs and ARBs. One thing different, you don't want to take it with high-fat foods. That could decrease the absorption. And these also must be protected in light, so, kept in these vials until the patient is ready to take them. So, again, we don't really see this used in practice. I'm not really sure why. It came out kind of in the late 2000s versus ACE inhibitors came out kind of in the early 2000s. I just think it never really took off because ACE inhibitors work so well, very well tolerated. So, not sure, but I promise you won't really see this used in practice that often. Alright, so let's talk about potassium-sparing diuretics. So potassium-sparing diuretics are similar to calcium channel blockers in the sense that we can subdivide them into kind of two different categories. So we have triamterene and amiloride, which have minimal blood pressure lowering effects, but we add them on to thiazide diuretics to help counteract potassium losses we can have from those drugs. And then we have spironolactone and eplerenone, which are the preferred add-on drugs for resistant hypertension. So they have more blood pressure lowering effects. So spironolactone and eplerenone are also used in heart failure. So a lot of good uses for this. And, I think if you guys remember, we also talked about spironolactone being used for acne because of those anti-androgenic properties that it has. Alright, so potassium-sparing diuretics work through antagonizing aldosterone receptors, so they block androgen, and spironolactone is non-selective, eplerenone is selective, so it kind of has less side effects. So they increase sodium and water excretion and at the same time conserve potassium levels. So listed to the right there, we have spironolactone, which I think we see used most commonly, unless, patients aren't tolerating side effects. We can use eplerenone, which is more selective. Then we have triamterene on its own, and we also have it combined with HCTZ, which again is one of the purposes of using those other two potassium-sparing diuretics. We can combine it with the thiazide, which is going to lower blood pressure a little bit, but more importantly, it's going to conserve the potassium losses that a thiazide diuretic might cause. So who are potassium-sparing diuretics a good option for? They're a good option for patients that are on thiazide diuretics and are experiencing hypokalemia, and they're a good option for patients with resistant hypertension, as in, it's not responding to other treatment modalities. Alright, so diving into some of the details about potassium-sparing diuretics. If a patient is hyperkalemic, we would not use a potassium-sparing diuretic because it's only going to further increase their potassium levels, which are already high. If they have severe renal impairment, we don't want to use potassium-sparing diuretics. If they have Addison's disease, which is a situation where the adrenal glands aren't producing enough hormones, we don't want to use something that's going to block more hormones, because that's not going to help either. So spironolactone, which is, non-selective and really is known for those hormone blocking properties, we wouldn't use in these patients. Some warnings there for amiloride and triamterene. For the hyperkalemia, it's more likely in patients with diabetes, renal impairment, again, that's why it's contraindication, or elderly patients. So definitely want to monitor potassium levels, right? We do want potassium-sparing diuretics to hold on to potassium, but we just want it to hold on to enough to keep it in normal range. So we do have to consistently monitor potassium, make sure we're not holding on to too much potassium. So some side effects here: hyperkalemia, increasing serum creatinine, dizziness, excuse me. And then for spironolactone, we can see, some of these hormone effects of the medication: gynecomastia, breast tenderness, impotence, irregular menses. Sometimes, in certain patients, transgender patients, we want to see the gynecomastia, so we can see spironolactone used in those patients as well. And then for eplerenone, we can see increased triglycerides, so monitoring those as well. All right, and some additional notes. We have another pharmacogenomic interaction here. Eplerenone can also have interactions with CYP3A4 inhibitors because it is a substrate. So this is very similar to the whole situation with the statins and the calcium channel blockers. But focus on the interaction with the calcium channel blockers. That one's going to be really important for you all. Alright, so some counseling points for potassium-sparing diuretics. Obviously, they can cause high potassium levels, so use other medications or supplements that can increase potassium cautiously. And these also have that lithium clearance interaction going on, and spironolactone can cause breast enlargement, and this is true for males or females. Doesn't happen in all patients, but good to let the patient know it may happen, so they're not like, oh my gosh, what's going on, And for some patients, they're not going to want this side effect, so this spironolactone would not be a good candidate for these patients if they start experiencing, unwanted breast enlargement or tenderness. Alright, we are moving on to the beta blockers. So for beta blockers, they're kind of split up into a lot of different classes. And on the next slide, I'll give you guys a little mnemonic to help remember at least the selective beta blockers, because those are the ones that we want to use more frequently than all the other ones. But yeah, so we have them split in between what receptors they're working on. So we have beta 1 selective blockers, and all of the beta blockers end in LOL, by the way. And then we have beta 1 and beta 2 blockers. Then we have beta 1 selective that also have nitric oxide vasodilation. So remember, we talked about nitric oxide in the patho lecture and how it can cause vasodilation. So nebivolol actually works on beta 1 and causes some nitric oxide vasodilation. Then we have non-selective, plus they have some alpha 1 blocking activity, so carvedilol and labetalol. Alright, so here is a fun mnemonic here to help you remember the beta 1 selective blockers. So the acronym is MAN-BABE. So if you think of this little man baby here, this is from the movie Boss Baby, by the way. I haven't seen it, but I thought it was really funny looking. So hopefully you'll remember this image and remember that these are the beta 1 selective blockers. So they target beta 1. One thing to note about beta 1 selective blockers, at much, much higher doses, they can still have some beta 2 blocking activity. So they're not, 100% exclusively beta 1 selective, but at lower doses and, kind of normal doses, we see predominant beta 1 activity. So this is why they're called beta 1 selective blockers. And we'll talk a little more on, what this means. Why would we want a patient to be on a beta 1 selective blocker, not on something that works on beta 1 and beta 2? Alright, so we're going to break up these beta blockers into their separate classes. So beta blockers competitively block beta 1 and or beta 2 adrenergic receptors. This is going to decrease heart rate and myocardial contractility. So beta blockers actually used to be considered first line also for hypertension, but now they've kind of fallen off and they're kind of more of like the add-on therapy. They're really only used first line if there is another indication for a beta blocker. So if a patient is post-MI, if they have stable ischemic heart disease, or if they have heart failure, then we would consider beta blockers first line. Now, the beta blockers, we said, end in LOL. These listed here are just the beta-1 selectives, and the dosing for metoprolol and succinate I always think is important because these are not interchangeable, right, tartrate and succinate, but when we convert them, the dose stays the same. So metoprolol succinate ER is the once daily formulation of metoprolol, so it's the Exol formulation, and then metoprolol tartrate is the one that is divided into 2 to 3 doses daily. So important thing to note here about beta blockers. Alright, so nothing super important to note from this slide. This is kind of just for your information, and again showing the different subcategories of beta blockers, where we have nebivolol, which has some nitric oxide dependent vasodilation along with beta-1 selective action. Then we have the non-selective beta blockers, propranolol, pindolol, timolol. Two things to note about these two. Propranolol we see used sometimes for anxiety too, because it crosses the blood-brain barrier, and timolol is only available as an ophthalmic, so we should not be using that for hypertension. Putting eye drops in your eyes is not going to have profound effects on your systemic blood pressure. And then we have the non-selective beta blocker and alpha-1 blocker, carvedilol and labetalol. Labetalol is another good option for pregnant patients. Alright, so we have a lot to say about beta blockers, so this slide was actually split up into 2 slides. So contraindications for beta blockers: if a patient has severe bradycardia, this is a low heart rate, is usually defined as under 60, under 55. If they have second or third degree AV block or sixth sinus syndrome, cardiac failure, cardiogenic shock, all of these things can be potentially worsened by beta blockers, so we want to avoid them in these patients. For esmolol, we also have contraindications if the patient has pulmonary hypertension or if they're using IV non-DHP calcium channel blockers. Now, an important warning for beta blockers is that we do not want to discontinue these medications abruptly. We need to gradually taper them over 1 to 2 weeks to avoid acute tachycardia, hypertension, and or ischemia. Because if we, just discontinue them over 1 day, we, put the patient at risk for these things. We want to use caution in patients with diabetes because sometimes this can worsen hyperglycemia. Sometimes it can prolong hypoglycemia and also mask the symptoms of it. And this is just because of the way the drugs work. So beta blockers are decreasing our heart rate. It's sometimes, it can be used for anxiety. So it's a little bit of an anti-anxiety medication slightly. And, when we think of the symptoms of hypoglycemia, those could be symptoms for some patients. Some patients experience a very fast heart rate. Some patients experience a little bit of anxiety, irritability. So beta blockers can kind of mask these symptoms by, causing them to not to show up as significantly as they used to. So important to counsel patients that have diabetes that, the beta blockers might alter the way that they usually recognize their own symptoms of hypoglycemia. We want to use this in caution with patients with Raynaud's. This is a condition where some areas of the body feel kind of numb, cold, kind of have some circulation issues going on in the fingers and toes. So this beta blockers will affect this condition poorly, so we don't want to use it with them. And then it can also mask the signs of hyperthyroidism. So one of the symptoms of hyperthyroidism is tachycardia. But again, beta blockers slow the heart rate down, so it can mask the symptoms of that disorder as well. And it can also worsen CNS depression. Alright, so another interesting little picture here to help you remember the side effects of beta blockers. The acronym is bald fish. I tried to Google images of a bald fish, but I couldn't find one. So instead, here's a picture of an old-looking fish who I'm going to assume is bald under that hat. So side effects of beta blockers are bradycardia, right? So decreasing the heart rate. We want that, right? But we don't want it to exceed a certain level, a certain rate. Arrhythmias, it can cause. So again, that's why, arrhythmias are a contraindication. Lethargy, so tiredness, dizziness, depression, fatigue, insomnia, sexual dysfunction, hypotension. Patients can feel a little lousy when starting beta blockers because of, some of these side effects, the lethargy, the dizziness, depression, fatigue, insomnia, all of those things. But again, because we don't want to discontinue beta blockers abruptly, we want to tell these patients that these symptoms are normal, to be expected. Some of them, right? We definitely don't want arrhythmias, but some of these more mild symptoms are normal, and they should actually improve over time as the body adjusts to this new heart rate and this new blood pressure. So monitoring, we obviously want to monitor heart rate, and we want to decrease the dose if we get to a heart rate that's less than 55 beats per minute, so that the heart rate can get back up to where we want it. And then obviously we want to monitor blood pressure for efficacy. So some additional notes here. In the same way that we don't want to discontinue beta blockers abruptly, and we want to taper the dose down, when we start a patient on a beta blocker and we're trying to get them to that target dose, we titrate the dose up slowly too. So we titrate it as it's tolerated. And what are we defining as the patient tolerates it? How are they handling those symptoms, the lethargy, dizziness, fatigue, insomnia, and how is their heart rate handling the increase in this medication? So one interesting note to make about Toprol XL is that it's one of the few XL drugs that can actually be split in half. So I'm sure you remember from, your drug delivery courses and all that foundational learning you guys had that we should not be cutting, crushing, chewing extended release formulations of drugs. But Toprol, just the way that it's designed, is one of the few drugs that we can actually cut in half if it makes it easier for the patient to swallow, or if for some reason the provider's got them on like 1.5 tablets or something like that per day, we can cut that one in half. Propranolol, I mentioned, has a high lipid solubility, which means it can cross the blood-brain barrier. So it does have more CNS side effects, but sometimes this is what also makes it a good agent for treating other conditions like migraines and anxiety. Labetalol, as I mentioned, is a drug of choice in pregnancy. It's one of the safer options for pregnant patients that have hypertension. And then lastly, we want to avoid non-selective beta blockers. So the beta blockers that work on beta 1 and beta 2 in patients with respiratory disorders, right? So if we think back to asthma and COPD and we think about why we use beta agonists for these patients, it should make sense as to why we wouldn't want a drug that is blocking beta 2 to be used in patients with respiratory disorders. So we want to use the selective beta blockers for these patients. Alright, so counseling on the beta blockers. Do not abruptly discontinue this medication, right? Definitely tell them about those potential side effects. If it's new for them, they might feel a little lousy at first, but it should go away, and really just tell them that we care about your health and it might be a little rough at first, but in the long run, this is going to be better for your heart, better for your blood pressure. For diabetic patients, we want to tell them that this medication can mask the signs of hypoglycemia, except for the sweating and hunger that might accompany hypoglycemia. So make sure when you're first starting it off that you're checking your blood sugars, or even after you've been on it for a long time, you still feel a little off, but you're like, I'm not experiencing my normal symptoms though, still check your blood sugars just to be safe. And then 1 point for carvedilol, always want to take it with food so that we can decrease the rate of absorption and decrease the risk of orthostatic hypotension. Carvedilol is a big offender for orthostatic hypotension. Alright, moving on to the centrally acting alpha-2 agonists. So these medications stimulate alpha-2 adrenergic receptors in the brain and reduce epinephrine, which we know causes vasoconstriction. So this is going to decrease systemic vascular resistance and heart rate. So they're listed to the right there. We have clonidine, which also comes as a patch, which is cool. It's like one of the only hypertension medications that comes in a patch. So we think, great for adherence. We have guanfacine, and we also have methyl-dopa, which is another option for pregnant patients. So this clonidine, the patch, is a great option for patients who can't swallow or patients who have issues with medication adherence because it's weekly. And these drugs in general are an option for patients with resistant hypertension because, again, they're not first line. We've tried all the other medications. Maybe they're still not where we want them to be. That's when the alpha-2 agonists might come into play. Alright, so what are the notes on the alpha-2 agonist? So methyl-dopa, we don't want to use that concurrently with MAO inhibitors or if a patient has active liver disease. For warnings, we don't want to discontinue these abruptly. These have high chances of having rebound hypertension, sweating, anxiety, and tremors if we discontinue these abruptly. So we taper them over 2 to 4 days. Methyl-dopa has a risk for hemolytic anemia or hepatic necrosis, rare risk but something to be aware of. And then some side effects of this, they're all just listed there, pretty general side effects that might happen. Clonidine, the patch, obviously will have potential skin rash, pruritus, or that itching or that redness around where the patch is applied. And then for methyl-dopa, sometimes we can see drug-induced lupus erythematous, or the dial. Very rare, but can happen with methyl-dopa. So monitoring, all things that make sense here: blood pressure, heart rate. We monitor mental status because of some of these potential behavioral changes from the alpha agonist, so irritability, confusion, anxiety, nightmares. Again, doesn't always happen, but just something to look out for, see if we need to use an alternative agent instead of this one if those symptoms are really bad. And then for Catapress, since it's available as a weekly patch, like I said, adherence is usually really high with Catapress. So speaking of the patch, let's go ahead and go over some counseling points for it. So the patch, like we said, is applied weekly, which is great for adherence. Only have to change it once a week. And you want to apply it to a clean, dry, and hairless area on the upper arm or the upper chest. Those are really the only two locations that we would apply a clonidine patch. Other patches, other medications, you kind of have more options than that. But for clonidine, this is where we want to put it. And you can apply the patch and put an adhesive cover over it if the patient feels like it's not secure enough, since it's got to stay on there for a whole week. And you don't need to remove it while showering, bathing, or swimming. The adhesive material that it uses should definitely keep it stuck on. One situation where you would have to remove it is before an MRI procedure. Alright, so moving along to the direct vasodilators. So these cause direct vasodilation of the arterioles. They have little effect on the veins, but what this is going to do is decrease systemic vascular resistance and blood pressure. So hydralazine is one of them, and it's available by mouth or IV. The dosing is every 6 hours, or 4 times a day, so it is a little inconvenient, but it does provide a lot of relief because it's a direct vasodilator. So this is an option for patients with resistant hypertension. And again, if we think back to nitric oxide and how we all have endogenous nitric oxide, which causes vasodilation for us without thinking about it, these direct vasodilators might be a good substitution for patients that potentially have this vasodilation deficiency for some reason, so they're correcting that. And then we have I can't even say it, minoxidil. This is actually Rogaine, so it's not used for blood pressure. It is used for hair growth. So it's a direct vasodilator, but it is not used for hypertension, which is why it's available over the counter. So moving on to the important parts about the direct vasodilators. Nothing really stands out for the contraindications, but for warnings, you have to look out for drug-induced lupus erythematous, and that is why we do an ANA titer. So that is looking for the autoantibodies that could potentially be involved in that reaction. And then another important counseling point for the direct vasodilators is that minoxidil, both of them are pretty strong antihypertensive medications. And this could lead to pericardial effusion and angina exacerbations. So for that reason, we always administer direct vasodilators with a beta blocker and a loop diuretic to counteract those effects, right? Because their primary mechanism of action is vasodilation. And this is going to cause the body to compensate by increasing sympathetic outflow, which is going to increase heart rate and sodium and water retention. So if we use a beta blocker and a diuretic, we counteract those effects. Alright, we have finally made it to the last class of medications that we're going to review for hypertension pharmacotherapy. So pretty exciting. So the alpha-1 blockers, this includes prazosin, doxazosin, terazosin, and tamsulosin. So they all end in that, zosin, sulosin, Flomax. So these bind to alpha-1 receptors, and they cause peripheral vasodilation of arterioles and veins. So these aren't generally used in hypertension, but if a male patient has benign prostatic hyperplasia, which is what we do use these medications for, and hypertension, then we can see these medications used because they're going to have that dual benefit for the patient. and they do have a high risk for orthostatic hypotension with chronic administration, so definitely something to let the patients know about. And these should only be used in addition to first-line agents, so they are never really used as monotherapy for hypertension. They're used on as add-ons and also preferred for patients that they're having this dual benefit for. Alright, so that was like a lot of medication. So you're probably asking yourself, okay, so when do I use this for what? And I kind of tried to allude to that with the whole, this is a good option for on the medication slides. But let's just do a recap of which patients might certain medications be best for when starting out initial therapy. So for non-Black patients, we have the most options. We can start them off on a thiazide, calcium channel blocker, an ACE or an ARB. All of these are appropriate first-line therapy for these patients. It's just going to depend on, what their blood pressure level is, if they have any contraindications to any of these drugs, anything, all that stuff. For Black patients, we want to use the thiazide or calcium channel blockers first. For patients with CKD, diabetes, with albuminuria, or CAD, we want to go straight to the ACE or ARB for initial therapy. Alright? And then if they have stage 2 hypertension, we usually start 2 of these agents at once. So we'll talk about different combinations that are appropriate in a bit. But I hope this is a good recap of, if I have this patient, what should I start them on? You have options, right? But good to know which patients we're jumping straight to the ACEs and ARBs, and which patients we don't want to start with ACEs and ARBs, period. Alright? Alright, so this is kind of another way to present that information from the DiPiro textbook. So we're now looking at, that algorithm on when to start treatment, and now adding on a little bit of, which treatment. So again, if someone has normal blood pressure, we're definitely not starting medications. We're just going to continue to promote the optimal lifestyle habits that they already have. If they have an elevated blood pressure, we're going to do lifestyle modifications and then reassess in 3 to 6 months. If they have stage 1 hypertension, this is when we look at ASCVD risk to determine, whether we're starting them on therapy or not. Also their comorbidities, whether they have diabetes or CKD. And if they do, let's just jump to yes, because we're going to talk about pharmacotherapy. If they do, then we can start them on an ACE, an ARB, a calcium channel blocker, or a thiazide. You can also consider RACE, like in the previous slide. And once we start them on one of those, we're going to reassess in 1 month, right? If they have a compelling indication, CKD, diabetes, we might start them on an ACE or ARB right away. Now, if they have stage 2 hypertension, we want to do a 2-drug combo of one of those first-line agents. Alright, so what combinations are most effective for patients? So there's like a ton of different combinations, like you can literally mix and match almost any of these drugs. But the preferred combinations are an ACE and a calcium channel blocker, an ARB and a calcium channel blocker, an ACE and a thiazide, or an ARB and a thiazide. So we have an ACE or ARB as part of all the preferred combinations, and then either a calcium channel blocker or a thiazide diuretic. So using combination therapy rather than just keeping all these medications separately is a great way to help achieve adherence to therapy. The only combination that is really a no-no is combining ACEs and ARBs, right? Because this is essentially a duplication of therapy. We've got too much activity in the RAS system. Alright, so let's take a closer look at what these combinations actually look like. So this first slide is those preferred combinations, so the ACE-ARB plus a CCB, or the ACE-ARB plus a thiazide. And we also have ARB plus calcium channel blocker plus thiazide, which is a triple combo. Great, very effective too. So a common ACE calcium channel blocker I see used a lot is amlodipine with benazepril. So the brand name for that is Lotrel. And then a common ACE and thiazide combination I see so much is lisinopril and hydrochlorothiazide. So the brand name for that is Zesteretic or Prinazide. So again, there's a lot of combinations out there. I'm not going to ask you guys to memorize every single combination possible, but at least be familiar with these ones that are bolded because they are frequently used, and understand, why these medications are combined, how they're targeting different ways to decrease blood pressure, and why it wouldn't be safe to combine an ACE and an ARB. Those are the big takeaway points about combination medications, as well as understanding that combining medications is going to help tremendously with adherence. Alright, and the next slide here, again, one of the preferred combinations, just couldn't fit it on the other slide, is the ARB and thiazide combination. Then we have beta blocker and thiazide combination, not as preferred, but still a good combo. And then we also have spironolactone combined with HCTZ. Again, spironolactone is going to help hold on to some of that potassium that the hydrochlorothiazide is losing. Alright, so this is a recap image of how at least most of the medications that we talked about were the big heavy hitter ones. So I'm sure you've seen, an image like this in a lot of the other lectures too. I just like to provide imagery to, complement all the wordy slides. So we have, the ACEs and the ARBs. The ACEs working here to block the ACE angiotensin converting enzyme. We have the ARBs working here. We have aliskiren directly inhibiting renin. We have the aldosterone receptor antagonist antagonizing aldosterone's effects. So all of these coming together, you can see how using different parts of the pathway are going to work in synergy and work together. We don't want to do too much though, and use an ACE and an ARB, or aliskiren and an ACE. That is too much in this one part of the pathway. And obviously the calcium channel blockers, beta blockers, the alpha drugs aren't here because they work in different areas, but this is at least a good image of the ROS system and where the drugs work there. So now we're going to move into resistant hypertension, hypertensive crises, special populations, all those things. So let's talk about resistant hypertension. What is the definition of resistant hypertension? So there are two criteria for when we would consider that a patient has resistant hypertension. So one is if a patient is on 3 antihypertensive medications at their full doses, and they have complementary MOAs, as in, they work in different systems. At least one of them is a diuretic. It's all this convoluted criteria. But if they're on 3 of these medications and they still don't have blood pressure control, then they're considered to have resistant hypertension. If a patient is on at least 4 medications and they do have blood pressure control, that is still considered resistant hypertension. Because the goal here is that we would like to not have this patient on 4 medications, but that is what they currently need to achieve blood pressure control. So those are the 2 different criteria for resistant hypertension. Now, treatment for this includes improving medication adherence, right? Maybe this patient's on 4 medications because 2 of them they're not even taking. They don't like the way it makes them feel. We want to identify and correct any secondary causes of hypertension, right? Because these medications that these patients are on work on primary hypertension. So if there is some secondary cause of hypertension going on and we haven't found it, that's why these medications aren't working yet. We want to address, other patient characteristics as well and look at the whole picture. Look at their lifestyle, rule out white coat hypertension, remove interfering substances, things that are acutely elevating their blood pressure before an appointment or even at home. Are they drinking a lot of coffee, things like that. So that is the general approach to treatment for resistant hypertension. We've already talked about, which drugs we might use in those cases. Alright, so let's talk about hypertensive crises. So hypertensive emergency, remember that is the one, had the typo on the last lecture, but thank you for the student that reached out to me to correct it. Hypertensive emergency is high, elevated, dangerously elevated blood pressure with end organ damage. Either they have it already or they're progressing towards end organ damage. So these patients we want to treat immediately with IV medications. We want to bring that blood pressure down quickly, about 25% within the first hour. So not like super fast, because that could cause damage too, but we want to decrease that blood pressure pretty quickly within the first hour, about 25%. And then after that, we want to get it to below 160 over 100 in the next 2 to 6 hours. Now, hypertensive urgency, again, there's no end organ damage. Doesn't look like we're progressing towards end organ damage. So we can treat these patients with oral medications, preferably that have a short onset of action so they can start working quickly, but we can treat them and lower their blood pressure gradually over 24 to 48 hours. So this algorithm here just shows that for a hypertensive emergency, we want to get them straight to the ICU. We want to evaluate if they have any dangerous conditions, aortic dissection, severe preeclampsia, or a phemochromocytoma crisis, anything like that. And we want to reduce the blood pressure quickly, but not, ridiculously quickly and cause some other problem. So we do it, the goal would be reducing the systolic blood pressure if they have one of these conditions to below 140 during the first hour and below 120 if they have aortic dissection. So aortic dissection, you guys can Google that. In hindsight, I wish I would have provided an image because it's really crazy, but the aorta basically has a tear in it, and blood that should be going through the aorta actually starts to pool out around that area. So I actually got to witness that in an inpatient setting one time after a patient had used cocaine. It was crazy reading the chart. I was like, you read about these things, you don't think they actually happen. But the patient was okay. They were able to use, IV medications to bring his blood pressure down. So happy ending for that one. And then if they don't have any of these conditions, but they do have some sort of other end organ damage we've identified to classify this as hypertensive emergency, we can reduce the blood pressure up to 25% over the first hour and then to 160 over 100, like I said in this table here. Alright, so what are the IV antihypertensive medications that we would use for a hypertensive emergency? Pretty much any of the antihypertensive medications that come as IV. Most commonly, we will see esmolol used, just very effective. Esmolol and nicardipine, I would say, are the ones that I see used most frequently. And so this slide here, this is for FYI. This slide here, this image here, FYI, let me write that there. But it just shows, depending on different conditions that are going on, different IV agents would be preferred, but very, very niche thing to treat, so I'm not going to ask specific questions about which IV agent would be best for which condition. Just know that you need to use an IV agent, not an oral agent, to treat a hypertensive emergency.